Hello and welcome to my clinical medicine stream. So, this will be the schedule for the stream, and if you see the screen, then I am taking a break or something of the kind. Stream will continue in a hot minute. But yes, this is my schedule, and the schedule is according to Indian Standard Time because I am from India. Okay, so let us see. General medicine generally has four topics which they can ask: a short case, two short case, and one long case from. So, in order to be prepared with everything, you need to learn these four topics very well. So, I'll not be doing the case performer in this episode because the case performer is something which you have to memorize, and there is no other option. But leaving the case performer, everything else you kind of have to read, I have to learn. So this will be targeting towards the Viva portion of the general medicine in postings and the clinical clinical postings, and in the finals when we have the Viva, and I will teach you how most common types of questions which they ask, how they will ask, and yeah, let's get on with the stream. Again, it's almost 12-hour stream. I have mentioned it as 24 hours. I have no intention to stop the stream without finishing everything which I promised to finish. So yeah, let's get on with it. Starting with, of course, cardiology. Is a stream working? Okay, it is working. I will give me a minute to troubleshoot. Which I promised to finish. Something which you have. Hello. Yes. So general medicine. I will starting with, of course, cardiology. Cardiology. Of course, cardiology. Okay, so everything seems to be in order. Let's get the class started. So first we have acquired and congenital heart diseases. So acquired heart diseases are possible include rheumatic, ischemic, cardiomyopathy, and degenerative. Valvular involvement includes mitral stenosis, mitral regurgitation, aortic stenosis, aortic regeneration, and others. With severity grading also should be there, with or without evidence of pulmonary artery hypertension grading. Okay, so heart diseases with evidence of pulmonary artery hypertension, which is with or without evidence of pulmonary artery hypertension, which is the grade and the grading. Then patient is in or not in atrial fibrillation. If atrial fibrillation is present, look for signs of thromboembolism. With or without evidence of heart failure, right and left congestive. With or without signs of infective endocarditis, and with or without sign of active rheumatic carditis. So patient is in NYHA, New York Heart Association, class 1, 2, 3 or 4. Example, acquired valvular heart disease, possible rheumatic etiology, the severe mitral stenosis and moderate mitral regurgitation with severe pulmonary artery hypertension, patient in atrial fibrillation and congestive cardiac failure with no signs of infective endocarditis, thromboembolism or active rheumatic carditis. Patient is in NYHA class 3. Like that you have to keep on writing and going. And this is the final in case of diagnosis you write all of these okay. For congenital heart diseases you have to provide the type of congenital heart disease. First is cyanotic or acyanotic heart disease, and the type of defect, shunt or obstructive, with or without evidence of pulmonary artery hypertension. With the grading, patient is in or not in atrial fibrillation. If atrial fibrillation is present, look for signs of thromboembolism. With or without evidence of heart failure, right, left or congestive. With or without signs of infective endocarditis, and patient is in NYHA class 1, 2, 3 or 4. Note, you have to mention if any features of dysmorphies or syndromes are present. Then example, congenital acyanotic heart disease with atrial septal defect with pulmonary artery hypertension, grade not given, with no evidence of mingerization. Patient is not in atrial fibrillation with no evidence of heart failure or infective endocarditis, and patient is in NYHA class 2. However, patient has features of Holt-Oram syndrome. Finally. And next we have discussion on cardiac cycle. We have systole and diastole. Systole is lasting for 0.3 seconds and diastole lasts for 0.5 seconds. That's why each heartbeat takes 0.8 second, and 72 heartbeats per minute is the norm. Then events of cardiac cycle. First you have S1, which is the closure of atrioventricular valves. Then you get click, which is the opening of aortic and pulmonary valve. Then you have ventricular systole. Then you have S2, closure of aortic and ventricular valves and opening of atrioventricular valves. Aortic and pulmonary valves will close, and the right atrium to right ventricle and left atrium to left ventricle valves will close in S2. Then isovolumetric relaxation. So First you have between S1 and S2 isovolumetric contraction. Volume will be the same, but there will be contraction. Then you have isovolumetric relaxation after S2 and snap. Then you have rapid filling phase. Finally you have diastasis, and then the S3 is heard in the rapid filling phase, and you have diastasis, and you have atrial contraction, which is the S4. Let us describe the cardiac events in the clockwise fashion, beginning from S1. So first we have S1, which marks the closure of the atrioventricular valves, mitral and tricuspid valves. Next you have isovolumetric contraction. Ventricles begin to contract, however the aortic and pulmonary valves are not yet open. This phase of ventricular contraction, where both atrioventricular valves and aortic and pulmonary valves are closed, is called isovolumetric contraction. And then clicks. Opening of aortic and pulmonary valves causes a sound called clicks. Ventricular systole. Immediately after opening of the aortic and pulmonary valves, blood in the ventricles is ejected out. S2. Next, the atrioventricular valves close, producing hard sound. S2. Isovolumetric relaxation. The ventricles begin to relax, but the atrioventricular valves are yet to be open. A phase where ventricles relax, but both atrioventricular valves and aortic pulmonary valves are closed, are called isovolumetric relaxation. Snaps. Opening of the atrioventricular valves causes a diastolic sound called snaps. Rapid filling phase of the ventricular diastole. Opening of the atrioventricular valve is followed by rapid filling of the ventricle due to pressure difference. Diastasis. The pressure difference gradually reduces and the flow between the atria and ventricle minimizes. This phase of cardiac cycle, where the blood flow between atria and ventricle is minimum, is called diastasis. Pressure difference gradually reduces, flow also minimizes. This minimizes is called diastasis. Then you have atrial contraction, which is the kick. Diastasis is followed by atrial contraction or atrial kick, which is responsible for pumping the additional blood into the atrium from the atrium into the ventricle. At the end of atrial contraction, the atrioventricular valves close, producing the hard sound S1, and then the cycle will repeat. Then, in a similar way, jugular venous also has a pressure waveform, which can be timed with other cardiac events. So S1, there is atrial relaxation, so X descent will be there. Then clicks due to tricuspid valve bulge corresponds with carotid upstroke, so there will be a C wave. Then there will be X descent again, descent of the tricuspid valve during ventricular systole. Tricuspid valve will slowly keep on coming down. Then V wave, atrial filling during ventricular systole. Atria will be keeping on filling. S2 and snap will occur. Then the Y descent during ventricular diastole. Right atria will be emptying. Okay. So then there is H wave, which occurs due to slowing down. Then there is A wave due to atrial contraction. So in a similar way, you will get just like that. You will get the jugular vein. This jugular vein. Okay, we will come back to jugular vein again, but yeah. Cardiac cycle PS following way ACX. We have to 4C3. Yeah. Okay, so A wave, it coincides with the atrial contraction, that's why it's called as A, and it is seen in diastole and precedes before the S1, it will come A wave. Then X wave, initial X descent, this is due to atrial relaxation, it is seen in systole, it is following the S1. Then C wave, it is due to bulge of the tricuspid valve, it is seen in systole, it coincides with carotid upstroke, it is absent in humans. There is no C wave. X dash wave, which is the X descent following C. It is due to descent of the floor of right atria due to downward pull of the tricuspid valve with continued ventricular systole. It is seen in systole. It follows clicks if the click is audible. Finally, you have the V wave, which is due to atrial filling due to ventricular systole. It is seen in systole. It precedes the S2. Finally, we have Y wave, which is due to right atrium emptying due to ventricular diastole. It is seen in diastole after the snaps, if it is heard. Finally, we have the H wave, which is not clinically appreciable. It is seen in diastole. It is a positive wave during diastasis. Next, we move on to cardiac murmurs, timing with other cardiac events. So, in case of cardiac murmurs, you have S1 clicks and all. After the S1, if you get a sound, then it is early systolic murmur. It is called when it is caused due to ventricular septal defect, small musculature, acute severe mitral regurgitation, and tricuspid regurgitation also cause early systolic murmur. In case of mid systolic murmur, it is aortic stenosis, pulmonary stenosis, hypertrophic obstructive cardiomyopathy. So imagine this properly. So S1, it is the ESM, means early. Initially the blood will be going from, during systole, the blood will be going from ventricle and all, no? Like if there is a early systolic murmur, then you can say that since the blood is also still coming near the walls of the atrioventricular wall, tricuspid and mitral walls, therefore if there is regurgitation over there, then you can hear it in early systolic murmur. Then for mid systolic murmur, because after pumping you have like you can assume, you can just keep it in mind, like it will go first to aorta, na? So aorta, it will go a little bit outwards. If there is a stenosis, there will be a sound in the aorta and pulmonary, that is mid systolic murmur. Then late systolic murmur is heard in cases where mitral valve prolapse is there, tricuspid valve prolapse is also there, and papillary dysfunction. Now you can finally assume some blood will go into the mid diastolic murmur and all the blood will go off. You can assume some majority of the part. However, some blood will also go to the mitral valve and the tricuspid valve. If there is a prolapse over there, then you get late systolic murmur. This is not a clinical examination, but you can just remember it this way. Then pansystolic murmur, you can hear it in mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Very similar to the early systolic murmur. However, pansystolic murmur is heard in all of them. Only in severe cases and small musculature, you can hear it in early systolic murmur. Then you have S2, then you have early diastolic murmur, you have mid diastolic murmur, and you have late diastolic murmur. Continuous murmur during all parts of the heartbeat also is there. So let me go in order. Early diastolic murmur is due to aortic regurgitation and pulmonary regurgitation. Now if you also notice, late diastolic murmur is a mitral stenosis, tricuspid stenosis, and atrial myxedema. You can see that how it is going. So first you have in systole, because you go out, the blood will be going out. Therefore, if stenosis is there, then you'll have mitral mid systolic murmur because of the stenosis. However, in case of diastole, where the blood might be coming back, like a little bit back, that time if you are having regurgitation, you'll be having like pulmonary, aortic and pulmonary regurgitation is there, then you will be having early diastolic murmur, if you understand. So in case of mid systolic murmur, because it's being pushed against the wall, you are getting, if the stenosis is there, then you'll get regurgitation. However, in mid diastolic murmur, because the blood is coming from the opposite side, if there is regurgitation, then you will be having mid diastolic murmur. In a similar way, because the atria will in late diastolic murmur is seen when the atria will be pushing it. If the stenosis is there, if the mitral stenosis is there, tricuspid stenosis is there, then you will hear the murmur in the late diastolic murmur and atrial myxedema. Okay, like swelling up of the atrial musculature, but okay. Then mid diastolic murmur, it is seen in what do you say, mitral stenosis, tricuspid stenosis, then atrial myxedema, all the three cases of the late diastolic murmur also, Carey-Coombs murmur, Austin-Flint murmur, flow mid diastolic murmur across the mitral wall, mitral regurgitation, aortic regurgitation, ventricular septal defect, ventricular patent ductus arteriosum, all of them across the mitral wall. across the tricuspid wall you have atrial septal defect, transposition of great arteries, and TR, atrial mixed edema, valve thrombus. If it is there, then you get mid-diastolic murmur, coronary atrium, and right murmur. All of these are not all important. Mitral stenosis, tricuspid stenosis is the main parts. You can also remember atrial mixed edema and flow murmurs. Mitral stenosis, aortic regurgitation, aortic regurgitation, ventricular septal defect, atrial septal defect, peta inductus arteriosum. All of them you can remember. Then again, these are all the how to remember. Early systolic murmur and PSM, pansystolic murmur, due to valve abnormalities of mitral and tricuspid regurgitation reasons. Mid-systolic murmur is due to valve abnormalities of the aortic and pulmonary wall, stenotic lesions. Late systolic murmur is due to prolapse of mitral and tricuspid wall. Early diastolic is due to abnormalities of the aortic and pulmonary wall, regurgitant lesions. Mid-diastolic is due to abnormalities of the mitral and tricuspid wall. Late systolic murmur is due to atrial mixed edemas. Early murmurs are regurgitation lesion. Late murmurs are stenotic lesion. Late murmurs are prolapse or papillary dysfunction or myxomas, which you can understand to remember how to remember. Then for continuous, you have coarctation of the aorta, atrioventricular fistula, uterine shuffle, memory shuffle, and then those are the main thing. Coarctation, patent ductus arteriosum. Now if you remember 2, aortovenous fistula also, if you remember, then that's more than enough. Then waveform, timing of the waveform with other cardiac events. You have atrial contraction follows the P wave of the ECG. Isovolumetric contraction and systole forms QRS wave. Then diastole follows the T wave of ECG. So timing of waves in ECG and pictorial representation. T wave is the QRS is the S1. S1 where you S4 is aortic will be pumping. S1 is where the ventricles start to pump. Isovolumetric contraction. Isovolumetric relaxation just before that is the T wave, and the S2 is the T wave. So again, as you can see in this image, ventricular pressure, ventricular pressure, A wave, C wave, and V wave, aortic pressure also, and ventricular volume shown. Finally, you have echocardiogram. So first P wave is diastole in the atrial kick you'll be having. Then QRS is the S1. Then T is of course the S2. P wave will not be having any sound. S1, S2. In cases of unless of course pathologically S4 if it is heard. Pressure again. This is very difficult to remember. If you can remember, you can, but it's generally not important. I think only one pressure might be important, which is the big one here. In the ventricular pressure, you have right ventricle peak systolic pressure is 30, left ventricle is 130. During the diastole it's 6 and it's 10. That's the only thing which we might require. Out also you may be requiring mean is 95. Peak systolic is 130 and diastolic is 80. Aortic pressure, ventricular pressure, and atrial pressure. It's given in the graph here. Aortic pressure is the only one which is very very high always, and ventricular pressure becomes very high during some parts. Peak systolic. Okay, 130 mmHg is the only important required thing. Then you have chest pain. Chest pain is a common symptom of cardiac diseases. It can be due to non-cardiac causes such as anxiety or diseases involving respiratory, musculoskeletal, and GIT. Cardiac, you have coronary artery diseases, angina pectoralis, myocardial infarction, valvular diseases, mitral valve prolapse, aortic stenosis, regurgitation, pericarditis, hypertrophic cardiomyopathy. Vesicular, you have dissection of aorta. Pulmonary, you have pleuritis, pneumothorax, pulmonary embolism, pneumonia. gastrointestinal reflux gastroenteritis, esophageal spasm, hernial hernia, hiatus hernia, peptic ulcer disease, cholecystitis, pancreatitis, costochondritis, arthritis, muscular spasm, bone tumor, shingles, herpes zoster, emotionally due to anxiety and depression. Yeah. So, differential diagnosis of chest pain. You have life-threatening causes, common non-life-threatening causes. Potentially life-threatening causes are acute coronary syndromes, EMI, STEMI, non-STEMI. Then you have unstable angina, pulmonary embolism, aortic dissection, myocarditis. Most common cause of sudden death in the young. Tension pneumothorax, acute chest syndrome, crisis in sickle cell anemia, pericarditis, Burr-Haves syndrome, perforated esophagus, gastrointestinal. You have perforated peptic ulcer, acute pancreatitis, acute cholecystitis. Almost all symptoms you can just keep on listing if you can remember. Tension pneumothorax is one of the main ones. Acute chest syndrome, crisis in sickle cell anemia, pericarditis, Burr-Haves syndrome. This is a perforated esophagus. Common non-life-threatening is gastrointestinal, biliary colic. Then acute cholecystitis is life-threatening. Another important one which you have to remember. Aortic dissection also is life-threatening. Myocarditis are most common causes sudden death in the young. Then non-common non-life-threatening gastrointestinal, biliary colic, gastroesophageal reflux disease, peptic ulcer disease, pulmonary. You have pneumonia, pleuritis, musculoskeletal vein, costochondritis, Tay syndrome, intercostal myalgia, neuralgia, fracture of the ribs, cough, trauma. Secondary is in the Bornholm disease. Thoracic reticulopathy, you have Texidor's twinge, which is precaudal catch syndrome. Emotional, you have anxiety, and natural shingles herpes zoster. Then differential features of ischemic heart and non-cardiac pain. So site of ischemic cardiac pain is central and it is diffuse, and non-cardiac is peripheral and it is localized. Character of pain: tight squeezing, dull consistency, choking or heavy feeling will be there in the chest, and precipitation is due to exertion and emotion. However, in non-cardiac, character of the pain will be sharp, stabbing or catching type of pain. It precipitates spontaneously and is not related to exertion. Then radiation. Ischemic pain will radiate to jaw, neck and shoulder, and the relieving factor will be rest in less than 5 minutes and nitrates. It will be associated features like breathlessness and diaphoresis. And non-cardiac pain, you will be having a lot of different pains. There is usually no radiation, however, and it is not relieved by the nitrates, and it depends upon the cause, whatever the associated feature is. So, differentiating features for common causes of chest pain, you have acute coronary syndromes, which is crushing, tightening, squeezing, operator like in the right retrosternal, left anterior chest RBS. Okay, radiation from right or left shoulder and arm, hand or jaw. It is associated with dyspnea, diaphoresis and nausea. Acute coronary syndrome. Then pulmonary embolism will be having heaviness and tightness. Whole chest will be affected, or it may be focal, segmental. Radiation will not be there, and it will be associated with dyspnea, unstable vital signs, feeling of impending doom if nausea, or just tachycardia, tachypnea if it is segmental. Then aortic dissection will be ripping or tearing type of pain. Whole chest will be affected, or a focal chest, and the radiation will be absent. No. Aortic dissection midline only substernal. Below the sternum, the pain will be there. Intrascapular area of the back also it may be radiating to. And secondary aortic branch occlusion, paraplegia may be seen. Secondary atrial branch occlusion. Then pericarditis or cardiac tamponade. This will be seen in cases where there is a sharp, constant or pleuritic pain will be there. It will be substernal. There will be no radiation, and it will not be associated. It will be associated with fever, dyspnea, pericardial friction. Then pneumothorax. It will be sudden, sharp, lacinating, pleuritic, and it will be located on one side of the chest, and it will radiate to shoulders and the back. It will be associated with dyspnea. sudden, sharp, lacerating, purity, pain on one side of the chest. It is pneumothorax. Perforated esophagus will be sudden, sharp, after forceful vomiting. It will be substernal and it will radiate to the back. Dyspnea, diaphosis, and signs of sepsis will be there. Types of angina. So angina itself is of several types, and the most important is until the variant angina of Prinzmetal angina. However, I'll just go to everything very fast. Angina is a symptom of myocardial infection that is recognized clinically by its character, its location, and its relation to provocative stimuli. Angina is stable when it is not a new symptom and when there is no deterioration in frequency, severity, or duration of episodes. Unstable angina is a form of coronary artery syndrome. It is at least one of the three features will be seen. Number one, it occurs at rest with minimal exhaustion, usually lasting for more than 10 minutes. Number two, it is severe and new onset, that is within prior 4 to 6 weeks. And number three, it occurs with crescendo pain, directly more severe, prolonged, or more frequent than before. Variant angina or Prinzmetal angina, it is caused due to coronary vasospasm. It will occur in the late night. So unstable angina occurs at rest without exertion, usually lasting for more than 10 minutes. It is severe and of new onset, usually within the prior 4 to 6 weeks. It occurs with the crescendo pattern, more severe and prolonged or frequent than below. Angina is stable. There's no symptom. Microvascular angina or cardiac stomachs. Angina like chest pain in context of normal epicardial coronary arteries on angiography. Episodic is pains which have characteristics of angina of effect due to occur at longer or shorter intervals. Nocturnal angina, it is seen in aortic regurgitation. Mechanism is prolonged diastole at night. Regurgitation time is prolonged. The related left ventricular mass will be increased demand will be there, and diastolic coronary stealing will be there, and venturi effect of atrial regurgitation jet. All of this leads in severe aortic regurgitation, causes nocturnal angina. Then angina decubitus. It occurs when a patient is lying down without any apparent cause. Occurs because gravity redistributes the fluid. Second will warm-up angina. In this, the patient with ischemic heart disease and excessive angina that forces them to stop. After the first part of angina, they are able to continue with even without any further symptoms of ischemia, preconditioning, and collateral recruitments are the proposed mechanism. Linked angina is associated with gastroesophageal and duodenal disorders, gallbladder diseases, cervical spondylosis. Then refractory angina is angina that cannot be controlled with medication and requires revascularization where it is not feasible. Status anginosus is a clinical term denoting the periods of frequent recurring angina pain at rest, indistinguishable to pain of cardiac infection or from prodromal manifestation without the echocardiographic and laboratory evidence of classical cardiac infection. Vincent angina is fuso or spirotracheal infection of the pharynx and the palatine tonsils causing also membranous pharyngitis and tonsillitis. We have Ludwig's angina, which is severe diffuse cellulitis that presents as acute onset, which spreads rapidly bilaterally affecting submandibular, sublingual, and submental space. Then you have abdominal angina, which is postpartum pain that occurs in eccentric valve occlusion disease, and angina seen dolor, painless episode of coronary insufficiency associated with diabetes mellitus, also called silent angina, associated with diabetes mellitus. So in angina seen dolor, the diabetic patient will not be able to feel the pain because they have diabetes and they are having peripheral neuropathy and all. No, neuropathy will be there, therefore we will not be able to feel anything. Then you have pregnancies. It is showing Canadian Cardiovascular Society, but it is wrong. You have to do NYHA, New York Heart Association classification. If it is there, I will do that on. It doesn't seem to be there, but I feel the same thing will be there in here also. Class 1 is it will be completely okay. Class 1 is angina which occurs due to complete during work exertion. It only occurs due to rapid and prolonged exertion work. Class 2 in NIH is I believe if it is breathlessness or pain dyspnea which occurs when running or walking up a slope, climbing up and down a stair rapidly, walking up a hill and all, in cold weather, in wind, under emotional stress after a few hours after walking, like that. And NIH class 3 occurs when there is, if you are going with your peers, then you're not able, however, if you're lagging behind and you're having chest pain, then it is NIH class 3. Marked limitation of ordinary activity there after 100 hours, 100 yards on the same level, or climbing up and down also might be difficult for you. And NIH class 4 is difficulty to chest pain, inability to button your shirts and all. And angina equivalents, it is seen in elderly and diabetes with nephropathy due to ischemic angina is absent and they are present with short shortness of breath, perspiration, diaphoresis, syncope, GI symptoms, abdominal pain, nausea, vomiting, fatigue, and confusion. Then you have palpitation, which is used to describe uncomfortable increased awareness of one's own heartbeat or the sensation of slow, rapid, or irregular heart rhythms. It is usually noted when the patient is quietly resting. Palpitation can either be intermittent or sustained, or regular or irregular. Change in the rate, rhythm, full stroke contraction can produce palpitation. Causes of palpitation. Common causes here cardiac arrhythmias due to immature atrial ventricular contractions, supraventricular, ventricular disease. Structural heart disease, you have atrial myxedema, valvular heart disease, congenital heart disease, cardiomyopathy, mitral valve prolapse, and pacemaker. All of these causes palpitation. Drug induced is alcohol, atropine, acetaminophen, caffeine, nicotine, cocaine, beta agonists, and theophylline. Psychosomatic due to generalized anxiety, major depression, panic disorder, and endocrine due to hypothyroidism, hypoglycemia, and pheochromocytoma. High output states in anemia, beriberi, fever, pregnancy, and thyrotoxicosis. Miscellaneous and idiopathic emotional stress, hyperventilation, premenstrual syndrome, strenuous physical activity. Then duration of frequency of palpitation. Duration may be either short-lasting or persistent. Note the onset and offset of the palpitation frequency. It may occur daily, weekly, monthly, or yearly. Regular, irregular, irregularly, irregular, irregularly, irregular. All of those are the classification types of palpitation. Extrasystolic, tachycardiac palpitation, anxiety-related palpitation. Anxiety-related is associated with anxiety episodes that begin and end gradually. Extrasystolic ectopic beats usually produce missing or skipping the beat or sinking of the heart is the split with periods during which heart beats normally. Patient report that heart seems to stop and then start again. It can often be seen in individuals usually without any disease of the heart and generally benign. In tachycardic episodes, rapid pulsation like beating wings in the chest. It may be regular in atrial tachycardia, atrial flutter, or ventricular tachycardia, or irregular or arrhythmic atrial fibrillation. Tachycardia, atrial flutter, and ventricular tachycardia is regular. So, associated symptoms and circumstances. Palpitation develop after sudden change in the posture, usually due to orthostatic intolerance to episode of atrioventricular nodal reentrant tachycardia. Appearance of syncope or other symptoms such as severe fatigue, dyspnea, and angina, in addition to palpitation, is more common with structural heart disease. Hypersecretion of natriuretic hormone results in polyuria, post-palpitation diuresis, and atrial fibrillation. Palpitation associated with anxiety or during panic attacks are usually due to sinus tachycardia, secondary to the mental disturbances. If there is mental disturbance, palpitation is associated. Hypersecretion of natriuretic hormone results in polyuria, postprandial diuresis, and atrial fibrillation. Occurrence of syncope or other symptoms in addition to palpitation is more common with structural heart disease. Then palpitation developing after sudden changes in posture or due to orthostatic intolerance. Associated with anxiety or during panic attacks or due to sinus tachycardia secondary to mental disturbance, and palpitation may be produced by an increase in the sympathetic drive during physical exercise. So, typical description of flipping flopping in the chest. Palpitation are sensed as heart screaming to stop and then start again, producing a flip flop sensation. This type of palpitation is generally seen by supraventricular ventricular premature contraction. Rapid letting due to sustained ventricular arrhythmia, including sinus tachycardia in the chest. Pounding in the neck, irregular pounding feeling in the neck caused by atrioventricular dissociation with independent contraction of atria and ventricles, resulting in occlusional atrial contraction against a closed tricuspid and mitral wall. This produces Canon A waves, which are intermittent increases in the A wave of jugular venous pulsation. Canon A waves may be seen with ventricular premature contraction, third degree of premature or complete heart block or ventricular tachycardia. Dyspnea. It is discussed in 2C. Syncope. Syncope is defined as transient loss of with uncertain before that loss by supraventricular or ventricular sustained ventricular supraventricular arrhythmia, including sinus tachycardia. Pounding in the neck is due to ventricular tachycardia and complete heart block. Canon A. Ventricular premature contraction, third degree at complete heart block. Complete heart block, third degree. Wait 1 second. Ventricular tachycardia and the ventricular premature contraction is in pounding in the neck and in flip-flop type ventricular premature contraction. Okay, then next we have syncope. Syncope is defined as transient loss of consciousness due to inadequate cerebral blood flow with loss of postural tone associated with spontaneous return to baseline neurological function without any re-escalative efforts. So, pre-syncope is the term used for lightheadedness in which individual thinks he or she may black out. Then, classical esophageal syncope. Syncope triggered by emotion or orthostatic stress such as venipuncture, experience or witnessed painful, noxious stimulant, fear of body injury, prolonged worsening, and heat exposure or exhaustion. Pre-syncope transient loss of consciousness due to inadequate cerebral flow with loss of postural tone. Without any resuscitative efforts. We'll come back. Mechanism. Global hypoperfusion of cerebral cortices or focal hypertension. Hypoperfusion of reticular activating system. One-third Indian may develop a syncope episode during their lifetime. Incident increases after with age, sharp increase at age 70. Cardiac symptom syncope has high incidence 24% of subsequent cardiac arrest. Cardiac causes arrhythmias, ventricular tachycardia, paroxysmal supraventricular tachycardia, long QT syndrome, Brugada syndrome, bradycardia, structural cardiopulmonary disease, cardiopulmonary disease, atrial stenosis, metrostenosis, IPS, pulmonary stenosis, obstructive cardiomyopathy, atrial myxedema, dissection, pericardial disease, tympanoid, pulmonary embolus, pulmonary hypertension, acute myocardial infection, and ischemia. Non-cardiac causes you have neurocardiogenic syncope, vasovagal or vasodepression or syncope, classical vasovagal syncope, situational syncope, carotid sinus syncope, glosopharyngeal neuralgia, micturition syncope. Orthostatic hypotension is seen in autonomic failure where there may be primary, example pure A autonomic failures or multiple system atrophy. Parkinson's disease with aortic pulmonary autonomic failure or secondary, example diabetic retinopathy all causes orthostatic hypotension. Then you have neurovascular syncope, which is due to reticular steal syndromes. Causes, then you have pseudosyncope, causes by stressors or metabolic or toxic abnormalities, hyperglycemia, encephalitis. You also have neurological syncope, which is a subarachnoid hemorrhage, transient ischemic attack, complex migraine headache, psychogenic induced syncope, and drug induced loss of consciousness, drugs of abuse, and alcohol. Okay, I'll just be back in a second. Then we have period edema. Edema is defined as abnormal fluid accumulation in the interstitial space that exceeds the capacity of physiological lymphatic drainage. Period edema is representation of various systemic and non-systemic diseases. So, approach to period edema. Site and distribution. Whether the period edema is unilateral or bilateral. Unilateral edema results mainly due to local causes like deep vein thrombosis, cellulitis, compartment syndrome, and filial lymphatic obstruction. Bilateral is due to systemic causes like congestive cardiac failure, anemia, chronic kidney disease, chronic liver disease, DVT, cellulitis, compartment syndrome, filial obstruction. Then duration of illness. Short duration of the illness is seen in acute causes like cellulitis, DVT, compartment syndrome, etc. It usually occurs in 72 hours. Association in pain, painless edema due to heart failure, hypoproteinemia, and lymphedema. Heart failure, heart failure, hypoproteinemia, lymphedema. Painful is DVT, cellulitis. Dull-aching pain is seen in chronic venous insufficiency. Variability of edema due to congestive cardiac failure and venous insufficiency is aggravated by standing and improves with overlight in limb elevation during sleep. Idiopathic edema is seen in female and increases during the day due to upright position. History of systemic illness. Symptoms of systemic illness like exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and chest pain point to cardiac failure. History of oliguria and puffiness surface suggests renal etiology. Long-term alcohol consumption, lowest discoloration of eyes and urine, abdominal distension points to cirrhosis of liver. Symptoms of endocrine disorders like hypothyroidism are often missed. Similar history about all other systemic causes of period edema should be elicited in detail. Patients who are bedridden for prolonged period of time have dependent edema over the sacral area. Hypothyroidism, long-term alcohol, etc. History of drug intake, calcium channel blockers, NSAIDs, and steroids. Trauma and radiation. Trauma and radiation can cause cellulitis, compartment syndrome, leading to period edema. Miscellaneous causes, obstructive sleep apnea, also lead to period edema due to right ventricular failure. Same thing which we have explained. Other symptoms, you have low cardiac output, fatigue, dizziness, syncope. Symptoms of pulmonary hypertension, exertional fatigue, exertional chest pain, exertional dyspnea. Fever, rheumatic fever, infective endocarditis. Symptoms of heart failure, fatigue, anorexia, weight gain, leg swelling, exertional fatigue, decreased urine output, perspiration, confusion, cough, hemoptysis, and wheezing. So, examination, general examination, vitals you have to take pulse, BP, regular venous pressure, anthropometry. Then physical examination, you need signs of infective endocarditis, fever, pallor, clubbing, splinter hemorrhages, mucosal petechiae, JNV lesions, Osler's nodule, Roth spots on the fundus. Signs of pneumatic fever, arthritis, erythema marginatum, subcutaneous nodules, and tachycardia. Clubbing will be there, petechiae will be there, subconjunctival hemorrhage, Roth spots in the fundus, Osler's nodule, and echocardiography showing vegetation. Stigmata of congenital heart diseases in Down's syndrome, trisomy of 31, child will be having many problems. ECD and ventricular cerebral defect is most common. ECD is endocardial cushion defect. So another feature you have to do, child has many problems: cataract, hypotonia, hypothyroidism, increased gap between first and second toe, which is the Sandel gap, leukemia, duodenal atresia. Child has Hirschsprung's, Alzheimer's, Simeon Crease will be there, many mental retardation, micrognathia, atlantoaxial instability, nystagmus, many problems. All of them is having to PP, protruding tongue, poor hearing, RR, round face, respiratory infection. Occiput is flat, oblique, palpable fissure. BB, brushfield spots, brachycephaly. LL, low nasal bridge, language problem. EE, epicanthic fold, ear folded. Mongolian slant, myoclonus. That's the main one. Then Marfan syndrome is aortic regurgitation, aortic or mitral regurgitation, and aneurysm will be there. Aortic aneurysm will be most common symptoms. Acranodactyly with hyperextensibility, subluxation of limbs and other joint deformities will be seen. Williams syndrome, you have paraventricular atrial stenosis, supravalvular atrial stenosis, patent pulmonary artery stenosis, pulmonary artery stenosis. Varying degree of mental retardation, Elfin faces, Williams syndrome, Elfin faces, upturned nose, flat nasal bridge, long philtrum, long malar area, white mouth, full lips, widely spaced teeth, periorbital fullness, hypercalcemia of infancy, all can be seen. Rubella syndrome, you have patent ductus arteriosus and pulmonary stenosis. Triad symptoms: deafness, cataract, and congenital heart diseases, including others include intrauterine growth retardation, microcephaly, macrophthalmia, hepatitis, neonatal thrombocytopenia purpura. Noonan syndrome, Turner-like syndrome, pulmonary stenosis, dystrophic pulmonary wall, left ventricular hypertrophy or anterior septal hypertrophy. Similarly to Turner syndrome, but may occur in phenotypic male without chromosomal abnormality. Then Holt-Ham syndrome, cardiac limb syndrome, atrioventricular and septal defect, absence of thumb or radius, cardiac limb syndrome. Laporte syndrome is multiple lentiginous syndrome, and pulmonary stenosis of congenital malformation. Long PR interval. I taken a skill now. This again, not all of them are required. I believe that's all that is important. Always one crevamed ectodermal dysplasia, atrial septal defect, single atrium, short stature of perinatal onset, short distal extremities, narrow thorax with short ribs, polydactyly, and nil hypoplasia, neonatal teeth. None of them are not useful. Dysart syndrome is also hypertelorism, short philtrum, long slanting eyes, hyperplasia, absence of thymus parathyroid, hypercalcemia. Dehlange-Charge syndrome may be required. Tetralogy of alert, truncus arteriosum, aortic arch anomalies, vesicular ring, interrupted aortic arch. Hypotropic obstructive cardiomyopathy, HOCM. So, Charge syndrome has coloboma, corneal atresia, growth or mental retardation, genocoronary abnormalities, ear abnormalities, and genital hypoplasia. Okay, next we move on to systemic examination. First you have inspection and palpation of heart. Tips of the fingers for localizing the palpation, metacarpal heads for appreciating the thrills, and heel of the hand to appreciate the heave. This image. So chest deformity, barrel shaped in COPD, carpal tunnel, broad chest like broad shield like chest, Turner syndrome, Noonan syndrome, pectus cavernatum, Muffin syndrome, Noonan syndrome, pectus excavatum, Muffin syndrome, homocystinuria, straight back syndrome in loss of normal kyphosis, expiratory splitting of S2, mid-systolic murmur, permanent pulmonary artery. Male gynecomastia, digitalis also perinolactone, hypomastia, mitral valve prolapse. Aortic area, pulmonary area, left sternal ball, tricuspid area, and mitral area. Precordial bulge, patient in supine position, stand in foot end of the bed. Look for precordial bulge. If present, indicates right ventricular dilatation in children. Basically seen in only with congenital heart disease like atrial septal defect. Costochondral costal cartilage ceases by 16 years of age. Cardiac diseases acquired beyond 60 years may not have a precordial bulge. Acquired as a heart disease that can produce a precordial bulge is juvenile mitral stenosis. Congenital heart disease like atrial septal defect, costal cartilage is few by 16 years of age. So cardiac diseases which are required beyond 16 years will not have a precordial bulge. Causes of precordial bulge: you have ribs involved, cardiac enlargement of the long duration, ribs not involved, example pericardial effusion. In case of cardiovascular causes, in non-cardiovascular causes, you have a skeletal deformity, bronchogenic carcinoma, mediastinal growth. Then apical impulse definition: it is the uppermost and lowermost part of maximum cardiac impulse. PMI, early systole, which imparts perpendicular gentle thrust to palpating finger, followed by a slight medial retraction in the late systole. First you have to see the character position, then the character. You have to palpate with the palm, then localize it with the fingertip. Observe the amplitude and duration of the lift of the palpating finger. If apical impulse is not palpable in supine position, the position can be put in left lateral position and examined again. Palm flat on the chest. Then you have features of normal myocardial impulse. Left fifth intercostal space 1 to 2 cm middle to midline or 10 cm from midline. Extent is 3 less than 3 cm or intercostal space. We have different types of abnormalities of apex. It is not absent or not seen or felt in cardiovascular pericardial effusion. It extracardia. Non-cardiac causes: behind the rib bit may be there, obesity or thick chest wall may be there, COPD, emphysema, left side arterial effusion, left side pneumothorax. Tapping type of vein bulge is seen in mitral stenosis, palpable S1, closing snap. Then hyperdynamic is seen in increase in amplitude, duration is more than a third. Okay, tapping is mitral stenosis, closing snap will be there, absent or not felt is one. Hyperdynamic, it is increasing in amplitude, duration is more than a third, less than 2/3 of systole. And occurs more than one intercostal space veins is called diffuse apex. Occurs in left ventricular volume overload condition. Example: physiological chin chest, rectus excavatum, high output states, pathological lateral regurgitation, mental regurgitation, mental septal defect, pedictus arteriosum, atrioventricular fistula. Then heaving type of what do you say? Heaving type of abnormal apical impulse is increase in amplitude, duration is more than 2/3, confined to one intercostal space, however, and it occurs in left ventricular pressure overload, not volume pressure. Atrial stenosis, systemic hypertension, it's HCM, which is hypertrophic obstructive cardiomyopathy, and concentration of water. Double apical impulse is seen in hypertrophic obstructive cardiomyopathy, left ventricular aneurysm, left ventricular dysynergy. tripolar wave impulse in HOCM again. Retractile in severe tricuspid agitation. Seesaw apex in left ventricular apex aneurysm. And epicogram showing different types of cardiac effects. What is ventricular? Which ventricle is causing apical impulse? Heart during systole becomes smaller. Generally, it draws from the chest wall, except for the apex. The effect of this withdrawal in chest wall can be observed as inward movement of chest wall during systole called retraction. Presence of lateral retraction identifies the apical impulse to be formed by right ventricle, which is an abnormal state. Presence of lateral retraction identifies the apical impulse to be formed by right ventricle, which is abnormal state. Wide area apex plate with medial retraction in ventricular enlargement. Right ventricular apex versus left ventricular apex. Right ventricular apex rotated and shifted laterally, lateral retraction. Left ventricular apex may be shifted down and out, medial retraction. In adhesive pericarditis, constructive pericarditis, systolic retraction at the apex followed by diastolic expansion is Skoda's sign, like the car. Displacement of apex, upward displacement in children, ascites, abdominal tumor, pericardial effusion. Downward displacement in medius nerve growth, aortic aneurysm, and lateral displacement if trachea is also shifted along with displacement of apex base. Then it is due to medius nerve shift due to a result of conditions such as lung fibrosis, collapse, pneumothorax, or skeletal abnormalities. If trachea is central but the apex is displayed, it may be due to left ventricular enlargement. Apex will be displayed down and laterally. Right ventricular is laterally only. Left parasternal pulsation or heave. It is either produced by right ventricle or left atrium. Normally, right ventricle activity is neither visible nor palpable. Heel is present in children with patients by placing pen over the parasternal area parallel to the sternum margin. Watch out the movement of the pen tip. Case of difficulty in appreciating the parasternal heel from breathing, ask the patient to hold the breath. All India medical CMs grading a parasternal heave. We have grade 1, which is not palpable, and ill sustained. Grade 2 is visible, palpable, obliterated, more than 50 cc in systole. Grade 3 is visible, palpable, non-obliteratable full systole. How to differentiate right ventricle and left atrium parasternal heave? Right ventricle parasternal heave with synchronous with apex, and it will be systolic. Left atrial parasternal heave not synchronous with apex, and it will be in diastole. Conditions where left parasternal heave pulsation are seen: physiological in children and reduced AP diameter. Right ventricular hypertrophy associated. You have pressure overload, pulmonary hypertension, pulmonary stenosis, volume overload, tricuspid agitation, atrial septal defect, ventricular septal defect. Regional valve abnormalities. You have RWMA of left ventricle, diakinetic motion of left ventricular septum pushes the right ventricle forward during the systole. pulmonary hypertension, pulmonary stenosis, hypertrophy, average distributed. There is no vascularity in tetralogy. Middle stenosis and regurgitation both have left artery enlargement and left ventricular hypertrophy. In very permanent parasternal, he will be seen mitral stenosis and mitral regurgitation. Then you have aortic and pulmonary pulsation. Sitting, leaning forward with breath held. Abrupt maneuver is a bit taught later. Pulmonary area, right intercostal space, left intercostal spaces, aortic, right and left. Okay. Visual pulsation, you have aneurysm of aorta can be seen. Chronic atrial regurgitation, peripheral heart sounds, A2 with SH18. Systemic hypertension, ejection click, bicuspid aortic wall, peripheral murmur, atrial stenosis, and dilated root atrial regurgitation. Pulmonary visual pulsation is seen in pulsatile pulmonary hypertension, PHDN, then pulmonary artery dilation, pulmonary artery aneurysm, hyperdynamic pulmonary artery circulation. Then P2 is diastolic shock. Ejection click is pulmonary stenosis. Pulmonary stenosis, failed ductus arteriosum, gram steel marble. Sternoclavicular pulsation caused due to aneurysm of each of aorta and thyroidea ema artery. Suprasternal pulsation. Right sternoclavicular joint. Yeah, aortic dissection. Aneurysm of aorta, aortic regurgitation, right aortic arch, baloor to sink shunt. Then I have application pulsation, which is raising the hand of the application, they will press downward. Ask the patient to take a deep inspiration and move the diaphragm down. Pulsation visible by pushing the tip of thumb or fingers downwards towards the feet. It would increase palpable right ventricular impulse. Transmitted aortic aneurysm pulsation causes the pulse of the palmar or pulp aspect of the thumb or hand. Transmitted hepatic pulsation also felt from the right side into the lateral surface of the examiner finger. Causes of gastric pulsation: left ventricular hypertrophy of any cause, causes cardiac causes. Aortic causes is embolic aneurysm, aortic aorta, aortic regurgitation. Hepatic causes, you have pre-diastolic or diastolic tricuspid regurgitation and systolic tricuspid regurgitation. Stenosis and regurgitation. Systolic is regurgitation and pre-systolic or diastolic is stenosis. Other pulsations at the back, you have Schussmann sign in coarctation of aorta, pulmonary venous fistula. At neck, you have aortic regurgitation, carotid aneurysm, subclavian artery aneurysm. Skoda sign is again. Let's go back. Skoda sign is systolic retraction of the apex followed by diastolic expansion. Idiopathic pericarditis and consecutive pericarditis. See. Systolic retraction of the apex followed by diastolic expansion. Yeah, during systole it should be contracted now. Instead of that it is going ulta. Okay, then next this sign. Schussmann sign in coarctation of aorta will be having Schussmann sign. Thrills are palpable murmurs, grade 4 or more intensity. It is described as purring of cat. Then, best felt with the head of the metacarpal bones. It can be systolic, diastolic or continuous. mitral apex. It will be systolic, diastolic. Systolic is severe mitral regurgitation. Mitral stenosis. Left sternal border is systolic is ventricular septal defect. Pulmonary artery systolic is ventricular pulmonary stenosis. Left sternal border is mitral apex is diastolic is severe mitral regurgitation. If it is systolic, then it's mitral regurgitation. Okay, diastolic because it will be pushing, left ventricle will be pulling, it will be going towards the left ventricle, therefore regurgitation will cause thrills. Diastolic will mid diastolic murmur is in mitral stenosis. No, late diastolic mitral stenosis causes late diastolic murmur. Pulmonary artery, pulmonary area is systolic, pulmonary stenosis. Aortic area, stenosis will be systolic aorta. So during systole, the ventricle will be pumping, stenosis will cause systolic. Diastolic is aortic regurgitation, severe aortic regurgitation. Left first intercostal space, continuous timing, patent rectus arteriosum, rupture of sinus of Valsalva. Diastolic thrills in the base of aorta, systolic. Thrills in apex of aorta, diastolic. Thrills in base of aorta, systolic. Other palpable regions of the apex are left ventricular S3, S4, left ventricular failure, mitral regurgitation, atrial stenosis, HOCM, hypertrophy of cardiac mitral regurgitation, atrial emulsion, CD, coronary artery disease, hypertrophic cardiomyopathy. Pericardial knock, specifically pericardial knock, is seen at constrictive pericarditis. Then high frequency sound S1 is tapping of MS, tapping apex of MS. OS, which is okay. OS is leads in diastolic sound in mitral stenosis. Ejection systolic click. Atrial stenosis, congenital bicuspid aortic valve, tumor PLOP, left atrial, right atrial myxoma. Murmurs, thrills is seen in mitral stenosis, aortic stenosis, ventricular septal defect. Diastolic is mitral stenosis. Murmurs and thrills. Okay, you can see, guess these. Other palpable sounds. Right ventricular is 3. Increased flow to the ventricles is seen in right ventricular failure, chronic tricuspid regurgitation, atrial septal defect. S3 will be there in atrial septal, chronic tricuspid regurgitation, right ventricular S4 is seen in pulmonary stenosis, decreased right ventricular compliance. High frequency sound, OS opening snap is seen in tricuspid regurgitation. No, tricuspid stenosis. Here also OS is seen in early diastolic sound in mitral stenosis. In parasternal area, it is in tricuspid stenosis. Murmurs and thrills, tricuspid regurgitation, and tricuspid stenosis. Note: palpable S1 is tapping apex. Palpable S2 is diastolic shock. Palpable P2, constrictive pericarditis, diastolic knock, or pericardial knock. This is the only thing which is important. Pericardial knock, constrictive pericarditis. Caudal flow. Dilated veins, caudal flow is due to superior vena cava obstruction. Cranial flow is due to inferior vena cava obstruction. Caudal flow, cranial collaterals are seen in coagulation of aorta. Example is Schussmann sign, seen in coagulation of aorta, where collaterals are seen in intrascapular, infrascapular region, below this, in between the scapula and in below the scapula. Then scars. Median sternotomy generally done when there is need of correcting a heart-lung machine, coronary artery bypass grafting. Medial sternotomy. Implanting electric devices. Minimally invasive surgery. Lateral thoracotomy is done for all valve replacement surgery. Patent ductus arteriosus surgery scar. Left thoracotomy, chest drain scars, and medial sternotomy is mitral regurgitation. A lot of things. Minimally invasive surgery. You can also have implantable device is there. Right thoracotomy is done for only pulmonary artery bending and blood lock dissection. This is really done. Left thoracotomy is for most of these. Drain scars, medium sternotomy is for a few surgeries. Then a few more topics are there. Tracheal tug. These days palpation and raising the chin of the patient and upward pressure on both the and apply upward pressure on both sides of cricket cartilage. It will be positive is downward pull with each heartbeat. Is a sign in aortic aneurysm. False positive is due to mediastinal mass. False negative is it does not move with heartbeat. And thrombosed aortic aneurysm. If it is a thrombosed aortic aneurysm, then it will be false negative. Okay, I'll take another break for some time. I'll be right back in a minute. Okay, so let's continue. I feel there may be a little bit of a delay. I don't think I can finish whatever I set out to finish in our half an hour, as there is more another 30 pages, and 1 minute per page will be very difficult to do. So let's keep on going, and let's see. I think it's all small topics. Only these murmurs might be difficult, and these auscultation sounds would be a little bit difficult. And after that, it's pretty safe sailing. As I tell you, and these both pages are incredibly important. However, I will not be doing them. It requires. It's a really good thing to stop at. I will just pause my class at this point, but I will not be doing them. It's very difficult to understand. So getting back. So percussion, why do you do percussion? Percussion you do only for finding out the heart border. Right, heart border from downward from the clavicular line up to liver dullness you have to do. Then one space above the liver dullness from the right midclavicular line to the sternum, keep on doing from the pleximeter, and then you just do it for the below two places. So if the dullness is corresponding to right sternal margin, then it is normal. If it is outside the right sternal margin, then it is pericardial effusion, and then dextrocardia, cardiac enlargement, right atrial enlargement, midsternal mass, lung pathology. Then left heart border, you have to palpate the apex. In the same intercostal space, go to the mid-axillary line and start percussing medially. Direction of percussion should be parallel to the left heart border, apparent left heart border. Normally it corresponds to the apex. If dullness is outside the apex, it's large pericardial effusion and left ventricular aneurysm. Here also it is pericardial effusion, dextrocardia, cardiac enlargement, right atrial enlargement, masses. Then these are all the same procedures. Honestly, if you can pause and read, it's good. But yeah, what I told is correct. This is the position of pleximeter you have to keep. Liver dullness. Then you have to do right side. Then left side you can do from the apex and a little bit above. Percussion of the pulmonary and aortic areas. Start percussing parallel to the right sternal ligament and percuss laterally. And normally it's resonant. For pulmonary area, start percussing parallel to the left sternal edge. Then Roach's sign. It is seen in moderate to large pericardial effusion causing obliteration of cardiohepatic angle. So percussion of the left intercostal space you have to do in the second intercostal space. Auscultation, you will get the Roach's sign. The Roach's sign is moderate to large pericardial effusion causing obliteration of cardiohepatic angle. Okay, auscultation. Hearing of human beings, capability is 20 to 200 hertz. Sensitivity is 1000 to 800 hertz. So minimum time gap to differentiate two sounds is 20 milliseconds. So characteristics of cardiac sounds: loudness is amplitude and intensity, pitch is frequency. So low frequency is less than 125, high frequency is more than 300 hertz. Low pitch is rough rumbling. For example, S3, S4 pericardial knock and mid diastolic normal. Mitral tricuspid mitral stenosis. It is better appreciated by well and pressure and by applying low pressure over the chest wall. If it is more than 300 hertz, then high pitch will be like soft blowing. Then it's S1, S2, extrasystolic contraction, early systolic click, opening snap, systolic murmur of mitral regurgitation, mitral aortic regurgitation. It is better appreciated with diaphragm of the stethoscope by applying firm pressure over the chest piece. Then topographical areas of the heart: mitral area, again it is this Gibson area, Erb's area, mitral area, aortic area, tricuspid area. It's very easy to remember them. So yeah, these five are the main areas, and Erb's area is left third intercostal space. You have a lot of other places: axilla, epigastrium, carotid artery, Gibson's area, As a seriatric supplementary, but they are all not important. So this is the order by which you palpate. First you do Levin and Harvey, including methods of teaching method of auscultation. Then you do apex. First you do apex. Then you do left axilla. Then you go to tricuspid. Then you go to epigastrium. Then you go to Ebb's point. Then the base of the heart, aortic and pulmonary area. Then clavicle, above and below, and finally you can do carotids. So apex, of course, apex is mitral area first. Mitral area first, then lateral, then Ebb's point. Then you can do the base of the heart lesions. And this is the aortic and pulmonary. And finally, no, first is apex, then axilla. Then you go to tricuspid. Right, apex, axilla, tricuspid. Finally, you go to Ebb's point. Finally, the aortic area and pulmonary areas. Position of the patient can be left lateral decubitus, supine, and sitting and leaning forward, which is the Erb's maneuver for pulmonary and tricuspid, pulmonary and aortic. When cardiac heart sounds, you have diastole and systole. S1, S2, as we have told, closing of the mitral and tricuspid valve marks the onset of ventricular systole, and S2 is closing of aortic and pulmonary valves. S3 is rapid filling of the ventricle. S4 is due to atrial contraction, filling of the ventricle due to atrial contraction. Others clicks, you can hear it from systolic sounds, which are called clicks. It can either be ejection click or non-ejection clicks. Snaps, which are diastolic sounds indicating opening of mitral and tricuspid valves. Pericardial knock is diastolic sounds, which is early. It is seen in constrictive pericarditis. Ejection C. Mid systolic click, opening snap. Images of different heart. Then we have S1, S2, and all of these things. So there are two audible components in S1, M1 and T1. Then there is two inaudible components, muscular in origin coinciding with beginning of left ventricular contraction, opening with similar noise respectively. And order of appearance is first inaudible component is M1, T1, then second inaudible component. M1 T1 interval is 20 milliseconds, so it's very hard to discern. Loudest at the apex coincide with cardiac obstruct. Determinants of S1 is structural integrity of the valve, position of the valve of the onset of ventricular systole. PR interval is inversely proportional. Aortic activity of the heart is directly proportional. Increased aortotropic activity. Loss of SU volumic contraction leads to soft S1. Then thoracic cavity, chest wall, high frequency murmur are more attenuated with soft tissues. So again, this is the one important thing which is actually required. If you learn this one thing, it's enough. Variations of S1 in metastenosis, it will be loud, it will sepal defect loud, tachycardia, short pair interval, hyperdynamic circulation in thin people. It will be soft in pansystolic murmur, atrial regurgitation and tricuspid regurgitation. Metastenosis also, it may, if it is having severe calcification, and atrial regurgitation if increased left ventricular filling and premature closure of mitral valves is seen. Bradycardia is there, long PR, heart blocks, obesity, emphysema, effusion. All of them will be having soft. Variable in atrial fibrillation, ventricular tachycardia, complete heart blocks. When you say allowed this one, if it is more and it's the same intensity of the mitral area in the base of the heart. Even in the base of the heart, if it is more, then it is loud. Splitting is seen as wide splitting and reverse splitting. And I'll just be back just a second. Okay, I'm back. Sorry for the 10-minute break. I had to get my food. So let's continue. So white splitting is seen in Epstein's anomaly, in atrial septal defect, in complete right bundle branch block, and in left ventricular pacing. Reverse splitting. We have T1 first, then the M1. It is seen in ectopic severe MS, complete left bundle branch block, and right ventricular pacing. Again, it's a little bit difficult to remember all of these, and I'm pretty sure you cannot even hear them. Mainly, you can hear a loud L1, but you will not be able to hear white splitting, reverse splitting, and all. Even T1 and M1, it's very hard to discern because 20 milliseconds is how much our ears can actually listen. Then you have a second heart sound where you have two components, A2 and then P2. A2 P2 interval is less than 30 milliseconds in expiration, and it is 40 to 30 milliseconds in inspiration. It is heard best in the base of the heart, pulmonary aortic. Loudest component is A2 and loudest component of S2 is A2. In the pulmonary area and in the aortic area is A2. Hangout interval is the time interval from the crossover of the pressure between the ventricles and the arteries to reach the actual closure of the valves. Is called hangout interval. Mechanism of normal split of S2. I am recording right. Okay. So normal split of S2 mechanism is during the inspiration there is increase in capacity. There seems to be an error. Let me just 1 second. And yeah, physiological phase disappears on the standing due to decreased venous return. So normal split is due to inspiration. There is an increase in capacitance of pulmonary vascular bed, and this results in delay of the rise of pulmonary artery pressure, resulting in prolonged pulmonary hang. Pulmonary hangout interval is between the interval between crossover of the pressure between the pulmonary ventricles and the arteries to actual closure of the valves. It is called as hangout interval. Again, this table is the main thing I feel, as always. Then, yeah, variation of S2. Loud is seen in hyperdynamic state, systemic hypertension, aneurysm of aortic root dilatation. Example: syphilis, ankylosing spondylosis, transposition of great arteries, and in pulmonary atresia. And soft is seen in atrial stenosis, atrial regurgitation, aortic sclerosis, thick chest wall, obesity, emphysema. Now look at this. A2, aortic stenosis, aortic regurgitation, and it is seen in mitral regurgitation, mitral stenosis, and all. Aortic is generally A2, and mitral and all is due to S1. Okay, then thick chest wall is seen as soft in A2. However, thin people, it is seen as loud in S1. Okay, obesity, emphysema, and all that S2. When you say A2 is loud, is similar to that. If it is loudest in, if it's louder in the apex and all mitral area as much as it is in the base of the heart. P2. P2 is considered loud if A2 it is as loud as A2 in the pulmonary area. A2 is generally louder than P2 even in pulmonary area. Okay, so loud P2 is seen in hyperkinetic states. What is it? Pulmonary hypertension, dilatation of pulmonary trunk, aneurysm of pulmonary artery, thin chest wall. Thick chest wall, thin chest wall will be here. Loud. Then condition of left to right shunt. Generally ventricular septal defect is left to right shunt. Then pulmonary stenosis will cause soft. Atrial stenosis, atrial regurgitation, atrial stenosis is soft PA2. P2 soft is pulmonary stenosis, dysplastic pulmonary valve, thick chest wall, obesity, and emphysema. So we have a lot of variations of the second heart sound. Splitting of second heart sound. Narrow split is seen in severe pulmonary hypertension, and wide and variable split is chest deformity due to early A2 is mitral regurgitation, mitral septal defect, and due to late P2 is right bundle branch block, left ventricular pacing, and ectopics from the left ventricle. is due to prolonged right ventricular ejection type, prolonged pulmonary hangout interval, right bundle branch block. Fixed split is to free communication between two atria, equalizing the pressure during inspiration and expiration. Already prolonged pulmonary hangout interval cannot be further prolonged. Paradoxical split. Reverse split is seen when P2 comes before A2. This is common in wider during expiration, and due to inspiration causes is due to either early P2 or late A2. So early P2, complete left ventricular branch, right ventricular pacing, PCVs of heart. VCV is premature ventricular contractions of the right ventricle, and late A2 is seen in due to severe atrial stenosis, severe systemic hypertension, and HCM, hypertrophic of cardiomyopathy, hypertrophic cardiomyopathy. So again, valvular diseases and S2. In mitral stenosis, there will be mild to moderate, it will be normal. In mitral stenosis, however, in severe mitral stenosis with the pulmonary hypertension, you have loud P2. Loudness will be there. Mitral regurgitation, you have mild to moderate, normal, severe will be wide, and it will be variable, A1 and A2. And mitral regurgitation with CAD, congenital coronary artery disease, or history of hypertrophic obstructive cardiomyopathy, you will be having reverse split. Then atrial stenosis, severe atrial stenosis, you will be having a loud P2. AS, severe AS, you will be having a reverse split. In severe AS, then atrial regurgitation, you will be having A2, loud A2. In mitral regurgitation, you will be mitral stenosis will be loud P2. Aortic regurgitation will be loud A2. Tambour will be there. Valvular pathology, you will be having A2, which will be soft. And that is all for S2. S3, only thing I'll just go to the main things. It is a low pitched lead diastolic best heard with a bell, also known as ventricular sound or pro-diastolic. Cause of S3 is physiological and hyperdynamic state. It is seen in children under 40, athletes, pregnancy, and other hyperdynamic states. Then pathological throughout diastolic or part of diastole. So pulmonary continuous murmur is seen in, first of all, systemic to pulmonary communication, patent ductus arteriorum, arteriopulmonary window, anomalous origin of left coronal artery from pulmonary artery, ALCAPA. Tricuspid arteria, truncus arteriorum stands from TOF surgery. Systemic to right heart connection, coronary atriovenous fistula, ruptured sinus of Malson. Left atrium to right atrium connection, Leuenberger syndrome, atriovenous fistula, systemic pulmonary, flow through constricted area, coarctation of aorta, peripheral pulmonary stenosis, renal artery stenosis, increased flow through normal vessels, venous cervical hum, cavalier Barnham murmur, arterial mammillary esophageal, mutant esophageal, thyrotoxicosis, tumors, hepatoma, hypernephroma. Then differential diagnosis of continuous murmur, systolic, diastolic murmur, and to and fro murmurs. Murmur in systolic, murmur in diastolic, but S2 is heard distinctively. Two murmurs separated by small silence, differentiating them from continuous murmur, because through different orifices or same orifices. So different orifices, it is a split defect with atrial regurgitation and mitral regurgitation with mitral stenosis. To and fro murmurs is stenosis with atrial regurgitation and pulmonary hypertension with pulmonary regurgitation. So grading of murmurs is again grade 1, 2, 3, 4 and 5, 6. Grade 1 is so faint only with special effect, murmur faint, immediately audible though, murmur that is moderately loud, and the thrill will be absent in all 1, 2, 3. Grade 4 is murmur that is very loud, murmur that is extremely loud and audible with one edge of the microscope touching the skin wall, chest wall, or like sound heard at Grade 6 is murmur so loud that without even touching the chest wall, it's still heard. Diastolic murmur by Ames also is similar, 1, 2, 3, 4. And then a soft thrill will be absent in grade 1 to 3, and 4 will be present. Character or quality is tonal effect of the murmurs. Blowing, musical, squeaking, whooping, honking, anything you can write on your own. Frequency or pitch related to the velocity of the blood at the site of origin in murmur. It is designed as a high, medium or low internal. Higher the velocity, higher the pitch of the murmur. Murmurs that emanate from areas of stenosis where velocity is lower are typically low to medium pitched. Then configuration of a murmur refers to its shape. To a large degree, it's a function of intensity and duration. Crescendo murmurs increase in intensity, decrescendo progressively decrease in intensity. Crescendo, descendo, decrescendo murmurs or diamond night murmur is a progressive increase in intensity followed by progressive decrease. Plateau murmurs maintain a relatively constant things. Mid-systolic, pan-systolic or whole systolic, early systolic, late systolic, early diastolic, left-sided, right-sided, mid-diastolic, and late diastolic, pre-systolic. When crescent continuous murmur, S1, S2, S1, S2, to and from murmur, it will come up, it will come down, it will come down. It will come down, it will come up, it will come down. Radiation and conduction. Radiation through non-cardiac structure, conduction is through non-topical conduction. So radiation will increase, intensity decreases with distance. Mitral regurgitation, murmur, PSM, radiates to axilla, tricuspid regurgitation radiates to epigastrium. Conduction intensity remains same or decreases with distance. And aortic stenosis murmur, ESM, early systolic murmur, conducts to the carotid. It is anatomical continuity through. Best heard with bell or diaphragm. Mid-diastolic murmur of mitral stenosis, tricuspid stenosis is best heard with bell, S3, S4, pericardial knock with bell. And systemic murmur of MR, TR, and mitral stenosis, and diastolic murmur of mitral atrial regurgitation is best heard with diaphragm. S1, S2 also, and extra ESC and opening snap. Then variation with position, left lateral recombinant position increases S1, LVS3 and LVS4. Opening sound of metal stenosis. Murmurs, metal stenosis, metal regurgitation, click and murmur of mid MVP. Austin Flynn murmur also. Left lateral recombinant. Sitting and leaning forward is lateral regurgitation and pulmonary regurgitation. Laying flat or passive leg raising in supine position is S3, S4. Valvular atrial stenosis, pulmonary stenosis, tricuspid regurgitation. It attenuates and systolic murmur of regurgitation, murmur of hypertrophy, obstructive, conductive cardiomyopathy. Mid valvular mitral valve prolapse, murmur and clicker delayed. It decreases CDM of atrial regurgitation, murmur of HOCM and MVP. Laying flat, passive lead housing, left lateral will increase the sounds and murmur. And sitting and leaning forward increases aortic regurgitation, pulmonary regurgitation. Then variation with respiration. Right sided murmurs increase on inspiration and left sided murmur increase on expiration. Tricuspid and pulmonary, whatever is there, it will increase in inspiration. Yes, at inspiration increases venous return to the right side of the heart by increasing fluid into the vena cava, but reduces venous return to the left side of the heart due to cooling of blood in the pulmonary venous capacitance vessels. Regurgitation stenosis of the same side, regurgitation stenosis of the same side, ventricular subdural defect, and pericardial drop. Expiration decreases the venous return to the right side of the heart by reducing venous flow, but increases venous return to the left side of heart due to collapse of pulmonary venous capacitance vessels, pulmonary venous capacitance vessels, and vena cava flow. Expiration decreases vena cava flow but increases left side heart flow due to collapse of pulmonary venous capacitance vessels. It also pulling of blood in okay. Carvalho sign when the murmur of tricuspid valve regurgitation gets louder with deep inspiration. Effects of inspiration on systolic murmur can be extenuated by employing Muller's maneuver. And yeah. Variation with other maneuvers, you have physiological maneuver. Sitting sort of isometric everything is there. Pharmacological intervention used is amyl nitrate modulation and intravenous infusion of alpha-adrenergic agonists, phenylephrine or methoxyamine. So, all of this we can do. Amyl nitrate, sitting forward, leaning forward. Valsalva will increase aortic stenosis, everything, metal regurgitation, aortic stenosis, and arterial stenosis, and MVP, and it decreases HOCM, and amyl nitrate also will decrease this metal stenosis. So, location of maximum intensity of murmur. Location seems refers to the point on the precordium where the murmur is heard with maximum intensity. Many systemic murmurs are audible over multiple areas of the precordium. Localizing the point of maximum intensity may aid in determining the site of their evaluation. In aortic stenosis, aortic sclerosis, Gala-Verdin phenomenon is seen. Two distinct systolic murmurs are heard. One high-pitched murmur in the aortic region, and the other musical systolic murmur in the mitral region. This is due to periodic wake phenomenon or hourglass murmur. Examples are how to describe murmur. It's useless. Innocent murmurs are those murmurs which are not due to recognizable lesions of the heart or blood vessels. Common in children and adults. So, someone's is sensitive. Changes with children's position when and respiration. Short duration, not holosystolic. Single, not associated with lip sync small murmur limited to small area, non-radiating, soft, low amplitude, sweet, no harsh sounding, systolic occurs during and is limited to systole. Examples of emotional memory. Hypertrophy, primary memory, encephal, autoexecutive, or diastolic memories. Nor pathological, not innocent. Continuous, you have some continuous part. Memory is of name murmurs, you have Gary Combs murmur, Austin Flint murmur, Graham Steele murmur, Reitard's murmur, Knox murmur, Millville murmur, Stills murmur, Gibson's murmur. Rheumatic fever was the only thing which is important. Gary Combs murmur, Austin Flint in late mid-diastolic in aortic regurgitation. Pulmonary regurgitation, high pitched Graham Steele murmur, diastole. Reitard's murmur is mid-diastolic, atypical murmur, incomplete heart block. Autosynesis is Knox murmur. Key Hodgkins. Rogers murmur in small ventricular septal defect. Kruger, Baumgarten, Venism. Okay. Auscultation from mitral stenosis. Patient in left lateral position, breath held in expiration using bell of the stethoscope. Time of murmur with carotid. Auscultation of is patient in supine position, breath held in inspiration using the form of the stethoscope. Increases on hepatic compression on passive leg raising. Murmurs with change in character and density. Again becomes infective and again it is atrial thrombosis, atrial myxedema. Pulsation of the liver is between the two pumps. Like this you put and you see the pulsation of the liver. It is seen in tricuspid regurgitation, aortic regurgitation, tricuspid stenosis. Systolic is regurgitation, diastolic is tricuspid stenosis. Also law is for fluid explanation against closed glottis. So yeah, knuckles on the intercostal space also. And I think this is it. Okay. So uses gestation tube dysfunction, early heart murmurs, also by increases murmurs in hypertrophic cardiomyopathy and mitral valvular relapse, and decreases them in atrial septal defect and aortic stenosis. Congestive heart failure, valsalva response is lost, and function of autonomous murmurs. Abnormal blood pressure, for example, absence of blood suggests abnormality of sympathetic system. Abnormal blood rate suggests abnormality of parasympathetic system. Valsalva can be used as a provocative test to check for neurogenic orthostatic hypotension, GRE malformation. Valsalva, when you are coughing, triggers headache in the back of the also it's not that important. Diagnosis and hernia, prolapse of uterus, and stress in can also can have living from a parasitic gland landing or inducible action. It is used to terminate an attack of supraventricular tachycardia (SVT). Going against closed glottis forever. Maybe 19 to Heart rate will decrease, blood pressure will increase. Yes, also known as small where force exposure followed by attempted force urination with a closed mouth. This risk can be used to evacuate weakness of soft palate and throat walls in individuals with obstructive sleep apnea. Okay, and that's all for cardiac. Again, it did take half an hour, but yeah, respiratory is a smaller chapter. Well, I say that, but a lot of things are there in respiratory also. This is I think this is abdomen. This is the respiratory. Respiratory is let's go down first. One 76. So 176 is standing. Again, cardiac and all honestly require a lot of things. So 176, and it starts from 176, 124, almost 50 pages. Again, this will take another 3 hours, so my timing needs to be updated again. Sorry. Okay, so diagnosis format: anatomical diagnosis, right or left lung disease with lobe and pleural disease. Pathological diagnosis: consolidative fibrosis, collapse, obstructive lung disease, restrictive lung disease, effusion, pneumothorax. You have to keep on going. Etiological diagnosis is tuberculosis, bronchogenic carcinoma, smoking, occupation, trauma. Complications like respiratory failure type 1 or type 2 or cor pulmonale. And yeah, after right all of them. Right upper lobe fibrosis, post tubercular etiology, no evidence of respiratory failure or cor pulmonale. Bilateral obstructive lung disease, emphysema secondary to smoking with evidence of type 2. Example 3, left sided pleural effusion secondary to malignancy, no evidence of respiratory failure or cor pulmonale. So, discussion on cardinal symptoms, including cough, expectoration, hemoptysis, dyspnea, chest pain, and others. Cough, run, and variable expiratory thrust of air from lungs through the air passages associated with phonation, which momentarily interrupts the physiological pattern of breathing. Mechanisms of cough production: cough reflex initiated by chemical or mechanical stimuli, and there is carried by afferents, which are type C and type 1 fibers. And what else is there? Cough reflex initiated by chemical or mechanical stimuli, carried by afferents, which are type C and type 1 fibers, and innervate pharynx, larynx, nasogaries. Terminal bronchiole and lung parenchyma. Afferents travel via vagus and superior laryngeal nerve. Nucleus rectus virilis NTS in brainstem is a cough center. Afferents travel via vagus, phrenic, spinal motor nerve to larynx, from producing cough. Spinal motor nerves. Mechanical effects during cough production. Mechanical effects involved in typical cough are fairly deep initial inspiration, tight closure of the glottis, reinforced by supraglotic success, quick and forceful contraction of the expiratory muscles, sudden opening of the glottis while the contraction of expiratory muscles continue. Yeah, makes sense. Classification based on etiology. Etiology can be respiratory causes, non-respiratory causes. And duration of cough, acute less than 3 weeks, subacute 3 to 8 weeks, chronic more than 8 weeks. Chronic cough with normal chest X-ray, cough variant asthma, typical eosinophilia, upper airway cough syndrome, aspiration, habitual cough, foreign body drugs, angiotensin ECE, chronic bronchitis, chronic idiopathic cough. Based on expectoration, it is classified as productive auditory cough, dependent on presence or absence of expectorations. Algorithm showing cough reflex. It is locations: larynx, supraglottic areas, tracheobronchial tree, auditory canal and tympanic membrane, pleura, pericardium and diaphragm, esophagus and smoke, frontis vagus, CNS modulation at CNS cortex through medulla nucleus tractus or aeratus. Again, vagus, phrenic and spinal, phrenic for diaphragm, vagus for larynx and trachea and bronchi, spinal motor for expiratory muscles. Classification: acute cough, respiratory cough, causes is tracheobronchitis, bronchopneumonia, viral pneumonia. Acute and chronic bronchitis, pulmonary embolism, sudden onset is bronchial asthma, asthmatic bronchitis, whooping cough and foreign body. Non-respiratory is left ventricular failure and GERD. Subacute is disease, bronchiectasis, post-viral toothache syndrome. Non-respiratory is intentional cough. Chronic cough lasting more than 8 weeks is COPD, asthma, interstitial lung disease, lung cancer, pneumoconiosis, asbestosis, leukocyte, anthracis. Mesothelioma of the lung, upper airway cough syndrome, and drug-induced ACE inhibitors, beta blockers, and SUDS, habit cough syndrome. Differentiation of types of cough. We have dry cough, productive cough, and brassy or vandal cough, and paroxysmal cough, baking, barking cough, spitting cough, and hacking cough, photogenic cough. Yeah. Different types of cough. Bone cough, loss of exposure, proximal cough is cough. This is the main thing, expectoration. Putnam can be classified as following: quantity, quality, odor. Modified MMRC. This is the main thing as I ask, and therefore it is highlighted. Grade 0 is breathlessness with strenuous exercise. Grade 1 is like heading on level ground or while walking up a straight hill. Grade 2 is walking on level ground. I walk slower than the people of my age because of breathlessness or have to stop for breath. Grade 3 is stop for breath after 100 yards after a few minutes on level ground. And grade 4 is too breathless to leave house, too breathless when dressing. And again, it's qualifies disability attribute to breathlessness. This is useful for characterizing baseline dyspnea in patient with respiratory disease. It describes baseline dyspnea, but it does not adequately qualify response to treatment of COPD. Yeah, NIH so is very similar. NIH is class 1 is without resulting in limitation of physical activity. Physical does not cause undue fatigue and all, and slight limitation of physical activity comfortable at rest. And marked limitation, they are comfortable at rest, less than ordinary work, causes fatigue, palpitation, dyspnea, and angina pain. Inability to finally severe 4 is inability to carry out any physical activity without discomfort. Symptoms of heart failure, angina syndromes may be present even at rest. Okay. Physical activities and discomfort increases. Then acute and chronic dyspnea. So cardiovascular system, we have cardiogenic acute pulmonary edema, chronic heart failure, myocardial ischemia. In respiratory system, you have acute severe bronchial asthma, acute exacerbation of COPD, spontaneous pneumothorax, pneumonia, acute pulmonary embolism, acute respiratory distress syndrome, inhaled foreign body in children especially, lower collapse, laryngeal edema, example anaphylaxis or obstruction. Respiratory system, you have chronic COPD, chronic bronchial asthma, bronchial carcinoma, interstitial lung disease, sarcoidosis, etc. Pulmonary thromboembolism, lymphatic carcinomas, last pleural effusions, anemia, obesity, deconditioning. Acute, you have non-respiratory non-cardiac metabolic acidosis, and in chronic you have psychogenic hyperventilation, anxiety or panic related. Acute this is lower column edema from bodies. And finally, we have chest pain. This is discussed later because chest pain is mostly a cardiac condition. I've already done it. Respiratory causes, upper sternal is tracheitis, pleuritic associated with breathing, and neurogenic is invasion of nerves. If neurological invasion due to tumor occurs, then it is neurogenic. Pleuritic is characterized by sudden and increased intense, sharp, stabbing or burning pain in the chest when inhaling and exhaling. It's exacerbated by deep breathing, coughing, sneezing, or laughing. When pleuritic inflammation occurs near the diaphragm, pain can be referred to the neck or shoulder. Pleuritic chest pain is caused by inflammation of parietal dry pleurisy and can be triggered by a variety of causes. Pulmonary embolism, myocardial infarction, pericarditis, aortic dissection, pneumonia, and pneumothorax are the 6 conditions that cause pleuritic pain. Pulmonary embolism, MI, pericarditis, aortic dissection, pneumonia, pneumothorax. God damn it. Other symptoms, you have nausea, breathing, hoarseness of voice, hiccups, and snoring. Nausea, breathing at laryngeal level is stridor, inspiratory sound. Oropharyngeal level is stritor. Tracheal level is rattling. Bronchial level is wheezing. Hoarseness of voice, you have inflammatory, acute, and chronic laryngitis, smoke, inhalation. Neoplastic, you have carcinoma, laryngeal papillomatosis. Recurrent laryngeal nerve damage, post-thyroidectomy, carcinoma, pleura lung. Neurological, you have myasthenia gravis, hypothyroidism, rheumatoid arthritis is involvement of trigoaretinoid joint, apical dysphonias, Ritke's dysphonia, sinus nodal vocal polyps, GERD. Hiccups is respiratory cause include basal pneumonia and pleurisy, and snoring is obstructive sleep apnea. Okay, and I will take a little bit of time. I want some rest, and I'll come back and do general discussion on examination. So yeah, my phone also is kind of very hot. So I will have to stop streaming for some time. I'll come back in another 15 minutes. And I'll continue, but my phone it's very hot, so this I'll genuinely just close the stream. It'll be showing a black screen, I believe, but when I come back it'll be proper. Okay, so yeah.